1. Therefore, it's not significant. So if you see a diagram like this on your boards and the confidence intervals are crossing the line of unity, it's non-significant. And down here, you'll see in the aggregate, 8.8% of patients given lytics died compared to 11.6% of patients given placebo, which means that the odds of dying are about here. They're about 0.8. And the confidence intervals are well below 1. In other words, this is highly significant. So that's sort of the basics of how to interpret these meta-analyses diagrams. As long as you remember those 2 or 3 basic facts, you'll be able to interpret these correctly in your board exams. I think, though, one of the most important things that we need to grapple with as a cardiology community is assessment of therapeutic effect. And I'm going to go through a couple of examples. So I've just shown you the thrombolytic meta-analysis. Now we're going to think about what is the strength of the treatment effect. So again, the placebo mortality is 11.6. The lytic mortality is 8.7. So this is a relative risk reduction of 25%, because 8.7 is 25% less than 11.6. So that's a relative risk reduction. However, the absolute risk reduction is 2.9%, 11.6 minus 8.7. Okay, it's 2.9. The number needed to treat to save 1 life is 34. Okay? It's 34. And this is simply calculated because you're saving, let's say, 3 lives per 100 patients treated. That means you have to treat about 33, 34 to save 1 life. This is the way I like to think about it, is the number of lives saved per 1,000 patients treated, which is 29. So this is the treatment benefit, the magnitude of the treatment benefit for thrombolytic therapy. About 29 or 30 lives saved per 1,000 patients treated. Just remember that number for a time being. So if you can understand that concept, you can then prioritize which treatments are most important for your patient. For example, beta blockers post-MI on average save about 6 lives per 1,000 patients treated. If you give aspirin for MI, 24, streptokinase, 25. If you change the streptokinase for accelerated TPA, you save an incremental 10 lives. Now look at this. ACE inhibitors post-MI, this is a performance metric for our hospitals. They only save about 5 lives per 1,000 patients treated. However, if you target the ACE inhibitor to patients with a low ejection fraction, then the magnitude of the treatment benefit goes up by an order of magnitude. Then you're saving 57 lives per 1,000 patients treated. So the way you use this information is if you have a patient post-MI with an EF of 35%, their blood pressure is maybe 9,500, you can't give both a beta blocker and an ACE inhibitor, which one are you going to prioritize? You're going to prioritize that drug that gives you the most bang for your buck. In this case, it would be the ACE inhibitor. So this allows you to make or inform your therapeutic recommendations for your patients. So the other thing I'm going to ask you is, what's of more clinical importance? Is it a 50% mortality reduction from 2% to 1%? Or a 50% mortality reduction from 20% to 10%? So this plays out all the time, particularly in marketing. So your drug rep may say that their drug reduces mortality by 50%. If you look at the numbers closely, you may find it's actually only 1 out of 100. Whereas this drug or whatever over here saves substantially more lives per 100 patients treated. So there are some references here for those of you who are really into this and want to read some more. But I'm going to stop the didactic portion of this, and now we're going to move on and do some interactive questions. I think Dr. Aman is going to come join me for this part. Maybe. And again, this is going to be a series where you don't need to do any calculations, but we're going to just do some thought experiments. We're going to take our time so that we all understand this stuff. And the first thing we're going to do is we're going to do some screening for coronary disease. This is a big thing nowadays, as you all know. So we're going to screen a low prevalence population. Let's say this population is an ambulatory population of outpatients or healthy people that have 2 or 3 risk factors. They have a family history, hypertension, hypercholesterolemia, former smoker, that kind of patient. In that kind of patient, the prevalence of coronary disease is less than 5%, okay? But they're worried about having coronary disease, one of their parents may have died young, whatever. They want you to screen. So what we're going to do is this patient's going to come to your office, and you're going to screen them with a very sophisticated technique. You're going to flip a coin, okay? You're going to take a coin, you're going to flip it, and you're going to say if it's heads, they have disease. If it's tails, they have no disease. So my question for you is, what is the negative predictive value of tails? So take your time, think it through. We're in no rush, right, Steve?
So the negative predictive values is 95%.
Very good, very good. So 70% of you selected the right answer, which is that the negative predictive value is 95%, okay? So this is great. So just think about this. A negative test means with virtual certainty the patient does not have coronary disease, okay? And what was your test? It's flipping a coin. It's meaningless. This is a meaningless test, but the negative predictive value is 95%, and you can legitimately tell your patient, because this test is negative, you've ruled out coronary disease. Now, you can charge a lot of money for a test that good, all right? You guys all know that. But the test is meaningless. So the point here being, in a low prevalence population, any test, even a meaningless test, has an outstanding negative predictive value. So if you read a paper that says this test is only good for ruling out disease, okay, in screening, throw that paper away. It's meaningless, because walking in your door, the negative predictive value is 95%. You do a meaningless test and they walk out with a negative predictive value of 95%. Yeah, you can do a more sophisticated imaging test and you can change that number to 97%, but still, I'm not sure that those tests are helping your practice. Steve, comments on that?
Yeah, I think that's right. I mean, particularly in a typical chest pain clinic, the negative predictive value walking through the door is 95 or 97 or 98%.
Exactly.
So let's go on to the next question.
So this is an important question that I hope most of you will get right. What does a p-value of 0.05 actually mean? A, that the results of the study have a 95% chance of being significant. B, that the probability the results are correct is 95%. C, the probability the results are wrong is 5. Or D, that these results could have arisen entirely by chance, but that the probability of that is 5%. So what do we think? Yeah, excellent. Yeah, this is absolutely the correct answer. I don't think we need to really go over it too much. It's interesting where this comes from. As best as I can tell, this comes from Ronald Fisher, who is an English statistician and geneticist, from Fisher's exact test, which is a statistical test. And in those days, they didn't have computers. They used slide rules. And 0.05 apparently was easier to calculate using a slide rule. So there we go. Okay, I'm sure many of you will recognize this. These are the main results of the PARTNER Cohort B trial. My question for you is, what is the magnitude of the treatment benefit at 1 year? So here's the standard treatment, 50.7% at 1 year. Here's the TAVR patients, 30.7% at 1 year. Okay? So here are your choices. What is the magnitude of the treatment benefit?
Let me go back one slide, because I've got the question there, and then they can look at the graph.
Okay, here are the numbers you need. So what is the magnitude of the treatment benefit? Is it a number needed to treat a 5? Is it a 20% absolute risk reduction? Is it a 40% relative risk reduction? Is it 200 lives saved per 1,000 patients treated, or all of the above? It's all of the above. All of these things are saying the same thing in this patient population. So if we just go back here, you'll notice that the absolute difference here is 20%. That's 200 lives per 1,000 patients treated. This is a huge treatment benefit. Remember, I just showed you the magnitude of treatment benefit for some of the medical therapy that we use.
So the 17% that answered B, you're right. That is correct. But the other ones are also correct. In fact, D says exactly the same thing. Just again, walk people through C and A.
Yeah. So if we look at the data here, 20% fewer patients died if they had a TAVI procedure. That means you're saving 20 lives for every 100 patients you treat, which means you have to treat 5 patients, only 5 patients, to save 1 life. This is the biggest treatment benefit we've ever observed in any cardiology trial. So this is a huge treatment benefit. This says the exact same thing, a 20% absolute risk reduction. The 40% relative risk reduction means that this 20% is 40% of that 50%. That's all that's saying. 200 lives per 1,000 patients treated, I've explained that. So in essence, these are all saying the same thing, using different units.
Yep. Now this question, just so you know, probably isn't one that would show up on the board's test, because if you were smart, you would have seen B and D are saying the exact same thing, and so you know the right answer is E. So the ABIM is pretty exacting in making sure that good test-taking skills don't lead you to the answer.
So now here's another study. I'm going to ask you the same question. This is the CURE study. Okay, you're all familiar with the CURE study. It formed the basis of some of the guideline recommendations for the use of clopidogrel in patients with coronary disease. So my question to you is, what is the absolute risk reduction on the basis of these data? So the placebo plus aspirin patients had a 1-year mortality of 11.4%. The clopidogrel plus aspirin patients had a 1-year mortality of 9.3%. And your local drug rep will tell you that there's a 20% relative risk reduction, okay? This is a huge risk reduction, 20%. So what is the absolute risk reduction? We live in an absolute world. Patients are either alive or they're dead. We're not in a relative world. You need to know what the absolute risk reduction is. So what do you think it is? Very good.
Now, Nishimura will tell you when he gets here that if you get more than 95%, you're allowed to clap for yourself. And he never achieves that with any of the questions he asks. So you're already ahead of Nish.
I think this question was too easy, Steve.
Okay.
All right. Let's get to graduate school now. So what we're going to do in the next question is we're going to recall our CCU rotation. So remember, in the CCU rotation, I said the negative predictive value was 50% because we had 180 negative tests. 90 of them were actually correct. In other words, 50% were correct. But let's say that we're working in the ED and we haven't had our biostatistics course yet, and that we choose to send these patients home. Okay, we're sending them home from the emergency department or from the CCU because they have a negative test. Now, they're not going to go out and die in the next 24 hours, right? Some of them are going to still do fine. So let's say over the next 6 months, only 30 of those 90 where we were wrong actually come back to hospital, okay? This is real life. You were wrong, but you got lucky because only 30 of them actually came back to hospital. So then my question is, what is the apparent negative predictive value? A, unchanged at 50%. It's worse because there's no gold standard here yet. C, the apparent negative predictive value looks better than the real negative predictive value. It's 150 over 180, which is 83%, or I can't tell. Very good. Exactly. You only found out about those 30. You haven't found out about the other ones yet. So the test appears to function better than it actually is. So this is something called verification bias. It's a really important concept in the real-life management of our patients. And that's it.